really good to see so many people here so that we can hear what you think of what we've planned so far and help us to develop those plans in a way that makes sense for you. So a big warm welcome. I'd like to introduce the panel members who've come along to talk to us. So first of all, from your left-hand end, there is Dr Henry Andrew, who's a consultant psychiatrist, Dr Sanjay Singh, who works in the CCG as the Chief GP Commissioner. Then we have Karen Ray from Kent not from Kent Social Services, but with Kent Social Services. And Ian Ayres, who's the accountable officer of the CCG, and Sue Scott from KCHFT, the Community Trust. Have we anybody in the audience from local councils? Okay. This is a listening event. Okay, we're here to hear your views. You may have come along to learn what the STP means, what it means for local care, and what the changes represent and might mean for you and for your families and everybody who lives in West Kent. It's really important that we understand what you think about this, because the last thing we want to do is leave you in a position where you're unhappy with what we're proposing. But it's also important that you understand the environment in which we work as commissioners, buying and planning the services, so that you understand the problems that we face with limited resources and rising demand. We haven't yet got firm proposals on. We haven't contracted with anybody to provide these services. We haven't drawn up business cases or costed these things. This is more about how we're feeling things should go, and so we want your views on that. The CCG is a clinical commissioning group, is accountable to many different people. It's accountable to the Secretary of State for making sure that we deliver our services within the cost that we've been provided within the budget. We're accountable to our GP members because they have elected us, the governing body, to do this work for them. But we're accountable to the population. We need to absolutely deliver the services that the population needs. I think that's all I'd like to say, apart from, you may have noticed there's some post-its and pens on the paper. If you feel that something's happening in the conversation that's not part of the agenda, or that we're missing something, scroll it on a post-it note and stick it on the double doors flip charts that are over there. Okay? Because it's really important that we don't dominate the agenda with what we're trying to say, and that other important things that might come up in your minds while you're having a conversation actually get captured as well. Okay? So, first half presentations, second half we're going to be getting the feedback and listening. There's an STP newspaper on the tables. There's a stall on the back for feedback of the evaluation criteria, which we'll be using to talk about stroke services, and all the slides that we're going to show will be on the website from tomorrow. Okay, any questions so far? Jolly good. Okay, so it's over to Sanjay, who's going to take us through the slides on local care.
Thank you, Bob, and good afternoon and welcome everyone. Thanks for taking out time to come in this warm, pleasant summer afternoon. Over the next 20 or 25 minutes, I'll take you through what our current thinking is on local care, and obviously your feedback will help us refine it further and shape it further. But before I talk about local care, I'd like just a couple of words about our NHS. there is a reason why we are so attached to our NHS, why we are so proud about our NHS. And you may say that it's coming from a biased GP. By the way, I'm a jobbing GP in Maidstone as well, which I forgot to mention. But it's not just that. If you take one of the big think tanks in the US, the Commonwealth Fund, which is most respected across the globe, it ranks NHS as the #1 health system in the top 10 industrialized countries. And has done, I think, twice in 2 years. And here we're talking about bettering the best. So there's a reason why we're so attached and proud about our NHS. Sorry, it's very sensitive. So first, just to explain what local care is. Local care is every health service and social service that is provided outside the main hospital, providing better access to care and supporting people's own communities. So when we set on this process, we're trying to think of what are we trying to achieve at the end of this. And the key emphasis that has emerged is to prevent ill health, to prevent the population from getting unhealthy in the first place. Deliver excellent care closer to home, which is more convenient for our patient population. Giving local people support to look after themselves, and I'll talk more about that as well. And early intervention at the earlier point, so you don't deteriorate too far down the line. And these thoughts were shaped by your feedback. We have done some initial listening as well. We had a survey of nearly 2,000 people responded. We had 2 listening events in March as well. And that helped shape our own thoughts. So your feedback, just a brief summary, was more support for end-of-life and dementia, more resilient GP services, health and social care working together, care near patient homes, and easier access. And your main concerns was about mental health services, social care, your worries around funding, resilience in general practice. And I think both in the wants and the concerns, the public was spot on. That's what bothers us as well. So it's coming from both angles, we are focusing on the same goals. But before we embark on solutions, I think we need to talk about what are the main key challenges facing us at the moment. So we are expecting a population rise by 2031 of nearly 400,000. The demographics are changing as well. We have people living longer, which is a good thing, and that has been an achievement of our past interventions in medical and the social front. But the services are still designed to serve a population which was there in the 80s or the 90s. The population and the demographics have moved on, and it's high time that the services frame themselves around the changing demographics. So, as many as 4 out of 10 emergency admissions could be avoided if there was right care in the community. There are 1,000 people in hospital beds at the moment who don't need medical intervention but are in a hospital bed. It's not a pleasant place to be from the patient's perspective. There are real recruitment problems as well. And the workforce, especially around general practice, has been a challenge over the past few years. So these were the key challenges around which we had to find solutions for the future. Prevention, I cannot overemphasize the importance of prevention. I think it gives biggest value for money. I know we're all taken about by the latest gizmos of heart transplant or putting a stent in the artery and opening it up. But in fact, that saves far fewer lives than simple steps like concentrating on exercise or smoking or obesity. And I think probably in the past our emphasis has been slightly skewed on that higher end of clinical care. And to get it right for the population and the individual, I think the focus needs to come back on prevention. And here are some of the examples that we wish to emphasize over the next few years. Like smoking, obesity, etc. Again, self-care is so important. Probably our focus has not been on that so much in the past. I remember my professor teaching me, Professor of Medicine, saying, when confused, the best person to ask is not your senior or the textbooks, is the patient. The patient knows best how much he or she is in pain. We second guess. How much breathless he or she is feeling, we second guess. To inform them, to support them, to involve them in their own care can only be a good thing. And I think if we are looking for good outcomes, we have to emphasize on self-care. I'll give you another example. Let's take a diabetes patient who is on insulin. If we're trying to adjust their insulin, I call them every 2 weeks, look at the blood sugars and adjust the insulin. It takes around 6 to 8 weeks or 12 weeks to get it right. If you educate the same patient to vary the insulin dosage as per his or her readings, you can achieve that in a week or 10 days. And that's empowering patients. They feel good about it. They feel in control of the disease. So I think self-care will be an important strand to develop going forward for us. And rightly so. So our foundation for local care, general practice at the core of it. It will be the bedrock of local care, that doctor-patient relationship that you are so passionate about and us doctors have so staunchly defended so far. That kind of long-lasting human relationship based on the ethos of care, compassion, and a bit of medical excellence. I think we need to preserve that. So in our strategy, we need to make sure that local general practice is thriving and resilient. The second is clusters, which is a group of GP practices. Third is local care hubs, and I'll go through each one of them one by one. But these were the 4 strands. Each setting will offer a different kind of care to our patient population, so there won't be any duplication. So as I was saying, general practice, we need to make it more strong, more resilient. I know in the feedback also, you were quite worried about the state of general practice, the stress it is under, and there are a number of factors which I'm sure you all are aware of, and I won't go into the detail of that. But that needs to be turned around. The answer probably is not only more and more GPs, because it takes around 9-10 years to train a GP, and we don't have the luxury of time, but other ways as well, looking at the overall workforce, what's needed for the population. And the 3 C's which we have put at the bottom, cooperate, collaborate, and combine. I think there's strengths in each general practice, which perhaps we haven't shared so well in the past. But coming together, sharing good practice, sharing even resources, a workforce, planning, all will help to mitigate some of the stresses in general practice and build up the resilience. I think locally we are already, 60 practices are combining to become a federation, which is a good starting place. We are looking at how closely we collaborate on wider projects, and I'll come to that in a second as well. And it's important to emphasize that combined doesn't mean practices disappearing in mergers and all that. Combining is combining your talent, your resources, talking to each other, talking about the patient population rather than just your list size. So that's at the core of our planning, and we're doing a lot of work on that. We are also working on extending access to general practice services, and that was one of the key things that came from feedback as well, and this part of the national drive as well. So hopefully we'll have even more provision out of our out of core hour services for our patient population. But it's important to emphasize that at the moment 54 out of 60 practices do offer some kind of extended hours. So the next thing is GP clusters. That is what I was alluding to earlier, practices coming together, collaborating, planning on a population basis. And we have already worked on that over the past year. As a result of that, we've got 7 clusters in West Kent. Each cluster will have a wraparound team of multidisciplinary professionals, social care, mental health nurses, dementia nurses, district nurses, pharmacists, etc. And they will work in a multidisciplinary way to look after the multifaceted, complex needs of patients who have got more than one long-term conditions, for example, who are frail. And the focus is to keep the patients well at home and that they have a positive experience as well. This is already happening. We are rolling out the multidisciplinary way of working in 2 clusters, and in a phased way we plan to extend it to the whole of West Kent by the end of this financial year. So that's the purpose of clusters. I've talked about health, but I didn't wish at all to exclude mental health. I think mental health is as important as physical health. And going forward, we need to ensure that we do that, and we need to improve services across the range of we need to improve a range of mental health services, especially when you are acutely unwell with mental health services. We have already commissioned a much improved services for children, which is coming to fruition and our operation in September. So a lot of good things should come out of it. Children and their parents should feel much more supported. But we're looking at the whole population spectrum, right from dementia and elderly to adults and to children, and also women, especially during pregnancy and just after pregnancy. So mental health is very important for us as well.